Okay, let's start with the other problem now. In hyperthyroidism, so same pattern as with hypothyroidism, there's a primary and a secondary and then iatrogenic cause as well. So primary, what do you think is the cause if it's primary? Since it's the same pattern as hypothyroidism. Primary cause would be what?
Issue with the thyroid itself?
Correct. So the problem with primary hyperthyroidism is autoimmune, just like what's the counterpart in hypo? What's the name of primary hypothyroidism? It's Hashimoto, right? Hashimoto disease. So in hyperthyroidism, the name is Graves' disease. This is also autoimmune, so therefore the patient's body has has antibodies. This time, these antibodies cause the increased production of thyroid hormones. So the patient's T3, T4 levels are high because of a defect of the thyroid glands. Now, in secondary hyperthyroidism, what do you think is the cause? What was the cause in secondary hypothyroidism?
It was the pituitary gland disorder.
Same exact story here. So here in hyperthyroidism, the primary form is Graves' disease. The secondary form is a pituitary problem. Patient has a tumor in the pituitary gland causing an increased production of TSH. So lab-wise, if the T3, T4 levels are high in Graves' disease, what will be the TSH level in Graves' disease?
It's gonna be low.
Correct.
Gonna be low.
Correct. So low T3, low TSH and high T3, T4 levels in Graves' disease in the autoimmune form. Now let's go to the secondary form. If the problem is with the pituitary gland and TSH levels are high, what will happen to T3, T4 levels?
Repeat that again. Can you repeat that, Professor?
In secondary hyperthyroidism, wherein the problem is with the pituitary gland, in which case it produces high levels of TSH, what will happen to the T3, T4 levels?
It will be low.
What's the purpose of TSH again?
Control the amount of C3 and C4 secreted.
So if your TSH levels are high, what will happen to the T3, T4 levels?
And a low.
It will be low.
Low.
It'll be increased.
It will increase, Professor.
Increase. Okay.
It's gonna be
High TSH will cause T3, T4 levels to rise as well. And the iatrogenic form here is what was the cause of the iatrogenic form of hypothyroidism? It was caused by what? Surgical removal or radioactive treatment of radioactive iodine or giving antithyroid medications, right? So that's why the patients went into hypothyroidism, meaning as a result of treatment for hyperthyroidism. Here, what do you think will be the cause of iatrogenic hyperthyroidism? Treatment of hypothyroidism. You treat hypothyroidism and then you end up giving the patient too much thyroid hormones. What will happen? What will the patient develop? Hyperthyroidism. Any question? Okay. Manifestations, this will be now the total opposite of what you saw in hypothyroidism. So if everything was slow in hypothyroidism, what do you think you will see here?
Everything is fast.
Everything is high. So let's start with the head. So the patient in hypothyroidism had dry, brittle hair, correct? So here the patient have thin, fine hair. There will be tachycardia, palpitations, so that will make you nervous, correct? Shaky. The patient will have goiter. Goiter is an enlargement of the thyroid gland because of hyperactivity and increased blood flow to the gland. I forgot to mention this. I'll go back to hypothyroidism after we discuss the manifestations here. There will be bulging of the eyeballs. There are two causes here. The patient has a increased deposit of fat behind the eyeball, and the other reason is there is eyelid retraction. The eyelid will retract back into the eye socket, meaning you won't see the patient's eyelid. So if the eyelids are missing, what will happen to the appearance of the eyeballs?
They'll bulge.
Okay, it will look like this. Okay, because there are the eyelids retracted. So therefore in that particular case, can the patient blink their eyes?
No.
Can they therefore moisten the eyeball?
No.
So what will happen? They have dry eyes now, correct? Can
Correct.
that be prone to injury?
Yes.
Does that need to be treated?
Yes.
Okay. So if we had cold intolerance in hypothyroidism, we will have heat intolerance here in hyperthyroidism. The patient has increased appetite and weight, but however, no matter how much they eat, the metabolic rate is so high that they cannot possibly eat 24/7. So therefore, they will continue to lose weight despite the increased appetite and increased food consumption. There's muscle wasting as a result. There will be no fat at all. The patient will be very skinny. In fact, they will be malnourished. They will go into a negative nitrogen balance because of this increased metabolic activity. They will have increased libido but unable to conceive because of the changes in the menstrual cycle. Here's the tremors or the shaking of the hands, as mentioned earlier. So they cannot sleep, whereas we had increased sleeping hours in the hypothyroidism. They were always sleepy. These patients cannot sleep. And how will you feel? Imagine you having all these manifestations. So you're feeling so hot. It's always hot, even in the middle of winter, and you're sweating. So can you get comfortable in bed?
No.
Does that help you sleep?
No.
Okay. So in advance of the intervention, so how will you promote sleep in these patients? Where will you put them? What room will you put them in?
A quiet room. And a cold room.
Close to the nurse's station or farther away?
Close.
To the nurse station.
Further away because they have to be quiet.
Correct. So cardiac manifestations, they have tachycardia, high blood pressure, which is opposite what you saw in hypothyroidism. Now let's go to management. Do these people need thyroid hormones?
No, because
No,
it's high.
it's already very high. Okay, so therefore we will instead give them anti-thyroid medications. These drugs will destroy the patient's thyroid glands. We'll look at the drugs and the nursing responsibilities later. Another option is to give them radioactive iodine. The purpose of this treatment is the only organ in the body that uses iodine is the thyroid glands. So therefore, when you give them radioactive iodine, where will this iodine go?
It won't go where it's supposed to because they have muscle wasting. So
Again, the only organ in the body that uses iodine are the thyroid glands. So when you give this patient radioactive iodine, where will this go?
the thyroid.
The thyroid glands.
The
Okay.
thyroid.
Okay, so therefore it will destroy or kill the patient's thyroid gland. And finally, surgery. So we can either remove the entire thyroid gland or a portion of it. So these are the three options to treat hyperthyroidism. Again, use drugs, antithyroid drugs, use radioactive iodine, or surgically remove it. Surgically remove a portion or the entire thyroid gland. Most common form for Graves' disease is radioactive iodine. These options here, using beta blockers, is not really for thyroid treatment. This will only be symptomatic treatment for what conditions that these hyperthyroid patients will develop.
High blood pressure.
The tachycardia and the hypertension. So this will not affect thyroid activity at all. This is simply symptomatic management. So this will help manage the cardiac manifestations of the disease. Let's go to the drugs. The drugs are called thionamides. They are right here. So there are two thionamides. They are methimazole and propylthiouracil. We'll get to the, I'm sure there's a chart or a table. There's a table. Okay, we'll get to that shortly. So that's the antithyroid medications. They're called thionamides. Radioactive iodine. So this is ingested by the patient. It can also be given IV. However, most common route is the patient will swallow the radioactive iodine. Obviously, it's contraindicated during pregnancy, and the incidence of hyperthyroidism is in younger women. So the incidence of hyperthyroidism, of Graves' disease, is women between 20 and 40 years old. So is that childbearing age?
Yes.
So what should be done before we start radioactive iodine?
Pregnancy too.
Pregnancy test, and that's it.
Mm.
So they just test them if they're pregnant. If it's negative, we start with the treatment.
No. You would have a conversation, find out if they're planning to get pregnant.
We did that already. So yeah, they're not pregnant. So do we start the radioactive iodine therapy?
No, we find out what your plans are. If you're planning to get pregnant.
Well, regardless of the plan,
and we tell you what the side effects of it is,
the medication.
that it could harm, it could decrease your chances of getting pregnant.
Yes, it's under treatment.
Say that again. I couldn't hear it.
Educate you and inform you that this will have an effect on you if you're planning to have children.
And no, they can get pregnant at any time, but do you want them to be pregnant? Because this word here is
No.
So you make sure that they're not pregnant. Besides the pregnancy test, what you would
again,
ultrasound?
Yeah, so we confirmed they're not pregnant. So can we start the treatment?
Yes.
Yes, Professor.
Yes, Professor.
They're between 20 and 40 though. What do 20 and 40-year-old women do? American 20 to 40-year-old. What do they do?
Go to school and work.
So they don't have sex?
No.
Yes.
They
Are
do.
they sexually active?
They sexually active.
So after we confirm they're not pregnant, can we proceed?
No.
Yes. Yes.
So we start the treatment right away.
No. No.
Okay, let's look at the next statement. So what do we do after we confirm they're not pregnant?
We asked them when was the last time they were pregnant, if they were pregnant.
Ask them not to get pregnant.
They should
Because
instruct
Okay.
them to not conceive for the last for
Okay,
at least
very
6
good. So
months.
how
for
do
the
we
tri-
do that? How do
And
we,
we educate them. We have a conversation.
And I educate them about it.
And then we also make sure that they don't have a young child, so they're not breastfeeding that child.
do we do
Birth
birth
planning.
do we
Birth
do birth control?
Yes.
Okay, that's what I want to hear. Okay, so they can't get pregnant when they're receiving radioactive iodine. Are we clear?
Yes.
yes,
Okay, they cannot get pregnant because what I mean by I should say really they should not get pregnant because they can get pregnant even if they take this. But what will their babies look like?
Deformed.
The babies will look like mutants, okay? Because their babies will be exposed to radioactive material, all right? And no breastfeeding, the child breastfeeding will also be exposed to the radioactive iodine. So what is used? We call the drug RAI 131. This is because there's a RAI 123, which is used to test the thyroid gland. So to treat the thyroid gland, to kill it, we use RAI 131. Now, this is a, because there are three forms of radiation. So this is internal radiation. When we say internal, obviously it's inside the body, correct? Because the patient swallow this, correct? So they swallow the radioactive material, and because it's unsealed, it will enter body fluids, meaning anything wet coming out of this patient is radioactive. So therefore, what precautions should they take? Anything wet coming out of this patient is radioactive. Saliva, urine, feces. Is feces wet?
Yes.
Reproductive secretions, no, semen, vaginal secretions, are they wet?
Yes.
Yes, so anything wet coming out of this patient, with exception of sweat. Sweat is okay, but anything else, saliva, urine, feces, reproductive secretions are all going to be radioactive. So take precautions not to expose family members to these body fluids. So for that purpose, can they have unprotected sex?
No.
Can they
No.
can they have sex, period?
Yeah.
Yes.
Yes, but with protection?
Well, is
No.
that 100%?
Not really.
Can you get all the fluids out of the partner?
No.
No, it's
No.
impossible. Okay, so no, they cannot have sex. Because other secretions are involved when you know, what have you heard about sexual activity that what other body fluids are involved besides reproductive secretions?
Saliva.
Saliva, okay. We'll get to the other precautions later. So as far as the toilet, using the toilet, what should they do?
You should double flush, I believe.
Okay, flush twice. Make sure there's nothing, no tinkles, you know, no drips on the toilet seat. Wipe them clean. What about if these patients are incontinent?
You have to use you have to
And make sure
Dab it
the
up.
diapers, anything soiled with the body fluids are disposed of properly. Can they share utensils,
no.
towels?
No.
And they finish off, let's say, you know, some people don't know how to eat chicken wings, they only eat the middle, leaving the really nice, crunchy, chewy ends alone. Can you finish that?
No.
Oh,
But it's a waste, you know, that's the good part of the chicken wings.
no.
No,
You can't finish it. It has to go to the trash.
okay. So here's the, so why should these women choose radioactive iodine over the antithyroid medications? Well, here's the reason. There are many side effects. Although we have side effects associated with radioactive iodine, there are even more side effects with the medications. Let's go to the medications short in a while. So what was the life-threatening complication of hypothyroidism? What was the name of that condition?
Myedema or
Myxedema. So there's also an acute life-threatening condition in hyperthyroidism. We call that thyroid storm. Now we discuss what's the condition of the patient in myxedema. So let's look at now what will a hyperthyroid patient who goes look like when they go into thyroid storm. Now imagine all these conditions here. Okay, so the patient already have these. Imagine having these symptoms, these manifestations, double, triple, or quadruple. That's the patient's condition when they're in thyroid storm. So what happens to the temperature? Very, very high. What happens to the heart rate?
Is it
low?
low?
Manifestations here. Can you see my screen? Are you looking at my screen?
Yes, Professor.
Okay.
Yes.
And there's the altered mental state here. They can also go into a coma. So similar to hypothyroidism. Now, how will a patient with hyperthyroidism go into thyroid storm? Here are the causes. Stress. What is considered stress to you? What is stressful?
like if they're exercising.
Only exercising? What if they're like one of you have
Life is
hyperthyroidism?
the stress with everything in life. Anything in life, like maybe the blood pressure.
Let's just talk about stress for now. So what is stressful to you?
School.
Okay, school, exams, right?
Mm-hmm.
Tests, quizzes, they are stressful. Clinical is stressful. So on top of the stress, there's the injury, infection, surgery, tooth extraction, any of these stressful conditions can trigger a thyroid storm. Any questions so far?
No.
Right. So therefore, what will we do before the patient, or if the patient is experiencing any of these? So what should we assess? And the patient has hyperthyroidism. Will you check the temperature?
Yes.
Okay.
Yes.
And the warning here is if the temperature rises by even 1 degree, if it rises by 1 degree, doesn't have to be fever. So let's say my initial temperature was 97. If it increases to 98, could that be thyroid storm?
No.
Yes, it is. Okay, again, if the temperature rises by even 1 degree, that could be an early sign of thyroid storm. Right? Doesn't have to be fever, because let's say the patient's baseline was 98. What if it reaches 99? It was not 98 1 hour ago. Now it's 99. And they have hyperthyroidism and they are undergoing an infection. They're admitted to the hospital for an infection, or they're admitted in the hospital for a surgical procedure, etc. Can that be thyroid storm?
Yes.
Yes. So what do we do now? The patient is suspected to be in thyroid storm. So notify a physician, and then these are going to be the orders. Cool the patient down, give oxygen, IV fluids. These are the 2 anti-thyroid medications. There's a table afterward. This will be given. Take note that it's or, okay? Not giving both, because both have the similar effects. So it's one or the other. Then you give hydrocortisone. That's a steroid to block the adrenal insufficiency. And then you give iodine preparations. I'll explain later where we're giving iodine. And then you treat these cardiac complications the same way as we treat. We will discuss dysrhythmia treatment, dysrhythmia management later, module 8. And you already know how to handle heart failure. So if they go into heart failure, you know how to treat them. And we already know about why is propranolol given again? Metoprolol, sotalol, why are they given? In patients with hyperthyroidism?
Tachycardia.
Okay, the cardiac manifestations. Okay, so we already discussed these earlier about precautions for patients receiving radioactive iodine. Let's go to the medications. So here are the drugs used. So we will focus on PTU, methimazole, and SSKI. Again, PTU, methimazole, and SSKI. Okay, look at the action of the drug. They block synthesis of thyroid hormones, meaning they prevent iodine from binding in the thyroid gland. What's the role of iodine in thyroid hormone production? Why do we need iodine in order to make what? In order to make T3, T4. You cannot make T3, T4 without iodine. Okay, so since the drug blocks iodine from binding in the thyroid gland, therefore the patient cannot make thyroid hormones without iodine, correct? And the drug prevents iodine from binding in the thyroid gland. Can you make T3, T4?
No.
No. So
No.
that's how the drug works. And that's how it decreases the T3, T4 levels. Now let's go to the SSKI. This is iodine, saturated iodine solution of potassium iodide. It is iodine, okay? So therefore, if you give iodine to a patient, would it not cause hyperthyroidism? Yes or no? You're giving them so much iodine. Will this cause hyperthyroidism?
Yes.
Yes, technically it will. However, if you give them a lot of iodine in a short period of time, it actually suppresses thyroid activity. How? Remember the last time you're already full? Let's say you went to a party or you went to a buffet. Okay, you pigged out. What happened after the second or third trip to the buffet table? Do you still want to eat?
No.
No more, right?
Definitely.
So if someone offered you another plate. Here, have some more. You paid for this. There's no limit to what you can eat. What will you say?
Nope.
No more, right? Because you're already full. It's the same principle here. So if you flood the thyroid glands with so much iodine at one time, it will actually suppress thyroid hormone activity, thyroid gland activity. So, since you're giving SSKI or methimazole or PTU, which should be given first? This one or this one? I described to you how these drugs work. How do they work again? They
This produces
prevent what?
prevent the production of C3.
How?
It doesn't produce it. It doesn't.
They prevent iodine from binding in the thyroid gland. So therefore, if that's how they work, they prevent iodine from binding in the thyroid gland, thereby no T3, T4 production. What will you give first? The iodine or the methimazole?
The methimazole, that one.
You will give this first. You will give this 1 hour before the
Mix with that so they can bind.
Right. Because if you give this first, what will happen to the patient?
Nothing, because it's not going to bind.
No, they will go into thyroid storm. This will happen. Okay, the patient will go into thyroid storm if you give them SSKI first, because this is iodine. This is a saturated form of iodine. This is an iodine solution. So you give this first or this first, and then 1 hour later, then you can give the iodine solution. Okay. And here are the rules. So because this is oral and it's iodine, so it can stay in your teeth. So you give it with a straw or give it with juice or milk. Okay, the meeting's about to end. I'll have to stop again and continue. Please